Okay, well, good afternoon. My name's Frances Batchelor and I'm the Director of Clinical Gerontology here at the National Ageing Research Institute. Welcome to our seminars in Ageing program. I'd like to start by acknowledging the traditional owners of the lands on which each of us are meeting today. And for me, that's the Wurundjeri Woiwurrung people. We offer our heartfelt respect to the traditional custodians of the lands, skies and waterways that sustain our work. We honour elders past and present whose wisdom, leadership and enduring care for country continue to guide our responsibilities to Aboriginal peoples, their kin and communities. So firstly, a little housekeeping regarding our teams. At the conclusion of the talk, we will have some time for Q&A. If you have any questions, you can submit them throughout the seminar using the Q&A function, which can be opened using the Q&A tab at the top of your screen. It resembles two speech bubbles, one with a question mark on it. The chat function is turned off, so please use the Q&A for any questions or comments. Your microphone and camera are turned off by default. And if you prefer, during the Q&A at the end of the session, you can use the raise your hand function in the meeting controls at the top of the screen with the hand symbol, and we will organise for your microphone and camera to be turned on so you can ask your question. Today's seminar will be recorded and uploaded to our website within a few days. Please keep this in mind if you're turning on your audio and video because you will be included in the recording. So today we're going to be hearing from Professor David Scott. David's an exercise scientist based at the Institute for Physical Activity and Nutrition, and we love an acronym, IPAN, at Deakin University. His research focuses on the epidemiology, diagnosis and management of sarcopenia, and he's led several clinical trials of exercise and nutrition for maintaining and improving physical function during ageing. His recent work explores the role of digital health in supporting older adults to self-manage musculoskeletal health conditions. He's published over 260 journal articles and received over $8 million in competitive research funding. He's also the chair of the ANZ SSFR's Sarcopenia Diagnosis and Management Task Force, and in 2023 he convened the International Remote Assessment and Management of Physical Function, the RAMP working group. And as you can see on the slide, David will be presenting on the development of recommendations for remotely assessing and managing physical function in older adults based on consumer and expert consensus. So welcome, David, and over to you.
Thank you very much, Frances, for the introduction. And I'd like to thank NARI for the invitation to present our work. Obviously acknowledging, as Frances mentioned, the Remote Assessment and Management of Physical Function, or RAMP working group. I too like a good acronym. So I will get my slides going. Now, as the name suggests, the focus of this process has really been around the concept of physical function. And I recognise that physical function is a somewhat nebulous term, but for the purposes of our process, we defined it essentially as the ability of a person to perform everyday activities independently. And so clinically, we will often assess this via objective assessments, tests such as gait speed, a hand grip strength, balance and sit to stand tests are all things that we might do to objectively measure someone's physical function. But we also have self-reported approaches as well, and instruments that we can use, such as activity of daily living questionnaires. In terms of how we're going to manage it, there's obviously no medications that are approved for improving physical function or muscle strength per se. So our first line approach really is generally going to be an exercise intervention with a focus on mobility, balance, resistance training. But there is very little evidence that routine physical function care is widely offered to older adults. And we see that particularly in general practice and community settings. because physical function is rarely being assessed, management programs are not really being offered. Where they are offered, it's probably usually in response to a fairly serious event like a fall or a fracture, rather than the less obvious but still clinically meaningful declines in physical function outcomes such as slower walking speed, deteriorating muscle strength. So we feel that, we're potentially missing a lot of opportunities for early intervention to support older people to maintain their independence. So our interest in, I guess, from there stems to increasing access to interventions for assessing and managing physical function. And one way that we've looked at this is via remote approaches, and that can include digital health. So we, like many others during the pandemic, conducted a number of studies exploring digital health approaches for improving physical function in older adults. And we believe that physical function as an entity, I guess, does lend itself quite well to remote care. So the diagnosis and treatments for poor physical function often can be well self-managed by older adults themselves with appropriate support and instruction, of course. And can be, as I say, done by themselves or perhaps done collaboratively with a healthcare professional using digital health platforms. So an example might be like you see on screen, somebody doing an exercise program in a Zoom meeting with other older adults involved and maybe an instructor. We might be able to do an assessment of a sit to stand test with someone on a video conference with their health professional, observing them do that test. So we think there's opportunities for remote care, particularly in the management of physical function. But as we're probably all aware, to date, we really don't know what the preferences are that exist for both older adults themselves, but also the health professionals that might be delivering these interventions. And the digital health tools that have been developed to date probably haven't generally been designed to take these issues into account. So to address this, in 2023, we convened the RAMP working group and decided that we would commence our work with a consensus development process. And so this involved two separate but linked Delphi studies. The first aimed at consumers, which were older adults aged 60 years or older, and the goal there to understand their beliefs and priorities regarding physical function and preferences for remote care. The results from this work were intended to inform a subsequent expert Delphi process. So the expert Delphi would include health professionals, academics, policymakers, to similarly understand their beliefs about the role of remote physical function care, both in practice and in research. And so the goal from these Delphi processes in combination was to contribute to recommendations for implementing and further research in remote care for physical function. Now, in addition to this work, we also had a subset of the Australian consumers from the Consumer Delphi process who we invited to collaborate with us in a co-design process to develop some digital resources to support older adults to self-manage their physical function. And so today's presentation is primarily about the Delphi process, but I will briefly touch on the early outcomes from the consumer co-design process at the end of the presentation. So for those who are unfamiliar with what a Delphi process is, it essentially involves a series of iterative surveys where statements are presented to participants and participants rate their levels of agreement with each statement. So after each round, the facilitator will review the results and the levels of agreement with the statements, and then we'll either see that those statements should be accepted, they've achieved consensus, or perhaps they should be rejected because they were widely had low agreement, or perhaps those that are somewhat in the middle with moderate agreement have the potential to be revised such that there's a chance that they could achieve consensus in subsequent rounds. So the facilitator will analyse, they will then potentially make modifications to the statements, and then in the second round, they'll present those modifications to the group. And the goal of this really is to allow participants to go beyond just thinking about their own opinions, but start to understand the opinions of other experts that are part of the group. And it's hoped that as part of that process, they'll start to potentially reconsider their own positions, move closer to the group in terms of their position, and hopefully a consensus is more likely to be achieved. And just by way of example, we've previously used this process with some success to develop the Australian and New Zealand consensus recommendations on diagnosis and management of sarcopenia. Sarcopenia obviously being the age-related decline in skeletal muscle mass and function, so closely related to the concept of physical function. But we were able to do this with both a consumer and an expert Delphi process. So for this RAM process, we decided we would follow a fairly similar approach. We decided we'd commence in 2023 with the consumer Delphi process. And the reason that we wanted to commence with consumers is that we felt it would be really important that their perspectives be taken into account in the subsequent expert Delphi process. It was our hope that that we might be able to deal with any preconceived notions that the experts might have about the acceptability of remote care to consumers by presenting them with those actual opinions that we'd collected in the consumer process. So we developed the initial consumer Delphi survey as a working group, and we also collaborated with two consumers to ensure that the questions and statements that we had developed were actually relevant and comprehensible for the target population of older adults. The round one survey included 23 statements, and participants rated their level of agreement with these using an 11-point Likert scale, where a score of 10 would indicate total agreement. And you can see an example of one of the statements on screen there. We presented these statements as well as a number of questions to understand the characteristics of the participants in an online survey. We advertised it via our international and clinical research networks, and also had worldwide social media advertisements in late 2023. We obtained the data in early 2024, and then using our predefined acceptance criteria, we analysed that data. Specifically, a statement was considered to have achieved consensus and would be accepted if 80% or more of participants gave it a score of 7 or more out of 10. Then statements with lower levels of agreement than this were classified as having moderate or low agreement and were analysed by reviewing participants' comments in free text. So we gave participants the opportunity to comment on each statement. When we looked at these comments and tried to understand the themes behind them, we could identify whether there was opportunity to modify it in such a way that we could address some of the potential concerns and hopefully increase its chances of being accepted with consensus in the second round. But for those where it was clear that any changes were not going to increase its likelihood of achieving consensus, that statement would be rejected. And so the revised statements were then presented to consumers in a round two survey, along with a document that was intended to explain the results from round one, but also the decisions taken in modifying the statements that we were presenting to them in round two. So looking at the results from the Delphi process of consumers, and just starting with their characteristics, you can see that in round one, we had over 650 respondents. The mean age was 69 years. About 3/4 of these were women, which interestingly seems fairly consistent with the kind of uptake that we see for many of our studies focused on physical function. This is quite anecdotal, but it does seem that we find older women have greater interest and/or concern around physical function than we see with older men, and perhaps something that we need to explore further about how we get that message to the older men. We had representation from 15 countries, but as you can see, the majority of respondents were from Australia and the UK, which maybe reflects to some extent the makeup of our working group. So in the questionnaire, we asked participants to complete the SARC-F instrument. Now, this is a screening tool for sarcopenia specifically, but it includes 5 questions which are highly relevant to physical function. You can see those listed in the table there. The majority of the consumers were well functioning, only having scores of 0 to 1, but about 30% had scores of 2 or more, which would indicate the presence of some physical limitation. We also asked them questions about their healthcare experiences. Notably, only about 1/3 of participants reported having a health professional ask them about their physical function in the last 5 years, whereas about 60% had tried to seek information on this from another source. And so this perhaps indicates that there is a little bit of a disconnect between the level of interest older adults have in learning about their physical function and maintaining and improving it, and perhaps the priority that it receives in their actual conversations with health professionals. Now, further into the remote care experiences, nearly 60% of the consumers had participated in some form of remote healthcare, supportive of current evidence that older people are increasingly familiar with digital health, particularly since the pandemic. But only about 5% had participated in a remote test of their physical function, and less than 1 in 5 had participated in a remote management program, such as remotely supervised exercise. So it does appear that the population was fairly naive as far as it comes to remote physical function care. Amongst those who had participated in any form of remote care, telephone calls were the most common modality, but for the few who had remote physical function assessment, this was most commonly done via a video call, which again probably makes sense that if you were to assess someone's physical function remotely, you would probably want to observe them on a video call to see how they perform a sit to stand test, for example. There was a fairly even spread of modalities used amongst those who had engaged in a remote intervention to manage their physical function. And it was pleasing to see that across the board, the experiences of remote care were generally considered to be quite positive. So we'll start by looking at the findings for the 23 statements included in the round 1 survey. The manuscript describing this consumer Delphi has just been published in the last week or so, so you can access it via the QR code on screen. It would be fairly boring for me to go through and describe each statement in detail, so I'll try to briefly summarize the key results over the next few slides. If you really would like to get into the detail, then I encourage you to download the paper, which is open access. So the first 6 statements of this consumer Delphi assessed the importance of physical function for older adults, and you can clearly see that it is a health priority. About 96 to 90% strongly agreed that having good physical function is important for their overall quality of life, being able to perform specific activities around the home and community. And it was also good to see that there was recognition among older adults that physical function can be maintained and improved even as we get older. We also saw agreement that older adults would like access to information on things that they can do to improve their physical function, but it was notable that this seemed to be more so that they could do things to manage it themselves rather than necessarily to aid them in having conversations about it with health professionals. And consumers also agreed that it would be safe for them to complete physical function assessments and exercise without direct supervision. But there was poorer agreement on whether they would like to participate in remote assessments of physical function and how they would prefer to engage with remote exercise, specifically the level of supervision that they would prefer. There was also no consensus achieved on whether people would prefer to engage in remote exercise programs alone or in group sessions, such as on a Zoom call involving multiple other older people. It was pleasing to see older people reported being comfortable using technology to engage with remote care. And then statements regarding any concerns about privacy, data security, and potential challenges of performing remote assessments and management programs in their home were pretty strongly rejected, suggesting that these are aspects of remote care which may be challenges, but probably can be managed. So at the end of round one, 13 of 23 statements were accepted to have achieved consensus. 2 round one statements, those that were related to the concerns around the use of technology or the suitability of their residences for remote care, were rejected. And so we had 8 round one statements that had moderate or low agreement, and these were revised into 7 new statements for round two. Now, an example of how we modified the statements and presented these changes to the consumers in round two is shown on the right of screen. So in this case, round one statements 16, 17, and 18 were regarding preferences for exercising and whether people would prefer to exercise remotely always, sometimes, or never under the supervision of a health professional. And so with the moderate agreement for these statements, we reviewed the comments, and the comments fairly consistently told us that the cause for low agreement was the differences in individual preferences for levels of supervision, and also recognition from the individuals that their preferences could change over time. Something else that came through quite clearly was that people felt that if they didn't have poor physical function in that particular moment, then they didn't necessarily feel the need to be engaging in such a program. So our approach with those 3 statements was actually to merge them into one new modified statement, which is statement 2.16, which acknowledged the importance of consumers believing that they needed support in order for them to engage, but also recognizing that they might have different preferences and that their preferences could change over the life of an exercise program. And so the round two statements, along with this document explaining how they were developed, were shared with the consumers in early 2024. Around 80% of the round one consumers responded in round two. And in round two, 5 of the 7 modified statements were accepted with strong agreement, including those related to having access to more information on physical function for self-monitoring and collaboration with health professionals, and willingness to participate in remote tests and exercise interventions for physical function. We didn't achieve consensus on willingness to participate in individual or group-based remote exercise, which I think is something we probably need to explore further, but probably again relates to those individual and changing preferences over time. Somewhat surprisingly, there was the statement regarding people being more likely to participate in remote physical function assessments if they were more confident that it was safe and accurate was rejected. And reviewing the comments on this, it just seemed to reflect that people didn't necessarily need to feel confident that a certain assessment is safe and accurate. They were happy to kind of defer to their health professional, and if they were told this would be an important thing for them to do, then they would rely on their expertise. There was strong agreement that having access to appropriate technology and exercise equipment would increase their likelihood of participating in remote exercise. So Finally, at the end of this consumer process, we ended with 18 statements that were accepted with strong agreement. And then the third and sort of final part of the process was, as a working group, trying to, I guess, consolidate these statements into some recommendations, and working together over time, we were able to consolidate the 18 statements into 7 consumer-informed remote care recommendations, which obviously now have been published, and we've also used to inform the expert Delphi process, which I'll talk about in a moment. But you can see the recommendations on screen here, and then the Delphi statement numbers that support those recommendations. But essentially, they revolve around the importance of recognizing that physical function is a health priority for older adults, that older adults themselves are aware that they can prevent, delay, and reverse declines in physical function, that we should be having regular conversations about physical function, and providing information that is accessible and reliable on how to monitor and maintain it. For those who have concerns about physical function, also facilitating assessments, whether that be in person or remotely. And similarly, for those who might need intervention, facilitating in-person and or remote exercise interventions as well. And then for those who are participating in those remote programs, whether it's assessment or management, making sure that they have the required support, technology, and or equipment to do so safely and effectively. So as I mentioned earlier, our reason for completing the consumer Delphi process first was that we wanted to make sure that this would inform the expert Delphi process. And so in a document that looked a little bit like this, we presented these findings to our expert participants when we commenced the expert Delphi process last year. This sat alongside the preamble to the round 1 questionnaire for the experts, with the hope that they would obviously take into consideration the opinions of consumers when sharing their own perceptions about the feasibility and acceptability of remote care for physical function. So the expert process followed a fairly similar protocol to the consumer process. Experts were defined as professionals whose work involves or previously involved supporting older adults to maintain or improve their health. The round 1 survey included 33 statements and was advertised between February and May 2025. And the round 2 survey was then shared with them in July and closed in August last year. So for this Delphi, we had 108 respondents in round 1. The majority of those were female. They represented 16 countries across 5 continents, although like our consumer process, the biggest proportion of participants came from Australia or the UK. The participants had an average of 13 years of experience working with older adults, and most were working in a metropolitan area. They were most commonly researchers who were working in academic institutions, but we had good representation of allied health professionals working in healthcare settings also. About 90% of the respondents reported that they were responsible for assessing the physical function of older adults, and about 80% reported being responsible for prescribing interventions to manage physical function. Amongst those who were responsible, only about 30% had used remote methods to assess physical function, and only about 45% had used remote methods to manage physical function. Those who had used remote methods to assess physical function had done so for an average of about 5 years, and they most commonly used physical function tests over things like screening tools and their own clinical judgment to remotely assess physical function. Video calls, written documents, and telephone calls were the most common resources used to support remote assessments. Then for those that had used remote methods to manage physical function, they had done so for an average of about 7 years, And they most commonly reported providing advice, education, instructions around physical function, as opposed to actually remotely monitoring or supervising physical function interventions. And so, unsurprisingly, I guess, written documents were the most commonly used materials to support remote management of physical function. So we'll look at the results now for the 33 statements. Again, I'll just try to summarize these. This paper is not yet published, but is currently under review at a peer-reviewed journal. If you would like access to it, I'd be happy to share it with you, and you'll have my contact details at the end of the presentation if you'd like to reach out. So as per the consumer process, there was strong agreement about the importance of physical function for older adults, although we only saw moderate agreement on whether remote methods are feasible and can be effectively implemented by experts. Similarly, there was moderate or low agreement about the time and cost-saving benefits of remote care, and also about whether remote care should be offered to all older adults or only those who are unable to access in-person services. But there was pleasingly strong agreement that remote care would be preferable to offering nothing at all. There was generally good agreement that remote methods would require consideration of privacy, data security. We need development of guidelines and also to increase access and also training in technologies for both consumers and healthcare professionals. The final set of statements focused on synchronous versus asynchronous delivery of remote care. Many of you probably understand those terms. For those that don't, synchronous refers to live supervised activities performed either in person or remotely. So an example of a remote synchronous activity would be that one that I've mentioned of observing a patient performing a sit-to-stand test in their home whilst the clinician at the hospital is observing them on a video call. An asynchronous example would be something that is perhaps unsupervised and done at a different time to the conversation with the health professional. So that might be where a patient receives written instructions for an exercise program. They do that at home by themselves, and then they send a text message or have a phone call with the health professional to let them know how they're progressing. And so you can see that there was only moderate to low agreement that either synchronous or asynchronous methods would be preferable to in-clinic assessments. And then there was generally low agreement that asynchronous approaches could achieve the same outcomes, engagement, and safety compared to the remote synchronous methods. So there does seem to be a preference for the live supervision of these activities as opposed to the asynchronous approach. So at the end of round one, we had 14 of 33 statements that were accepted. 10 were rejected and 9 were modified into 11 new statements. These were presented to the experts in July last year, along with a summary of the changes made to the modified statements. You can see an example of that document on the right of screen. One of the important changes we made was actually to include a umbrella statement, because when we were reviewing the comments on statements that had low agreement, consistently we saw experts stating yes, but, which is essentially they kind of agreed with the statement, but they felt that it would be really important to specify that older adults should be physically and cognitively capable and also have access to the requisite equipment. So we created this umbrella statement that sits above the each of these revised statements, which specifies that for community dwelling older adults who have adequate cognitive and physical capacity and access to and familiarity with technology, ... The statement would follow from there. And so this was included as a preamble on a number of the revised statements, which you will see on the next slide. We had 82% of our round one experts respond in round two, which was a fairly strong response rate, pleasingly. And you can see the new umbrella statement presented in italics here. And with that caveat in place, we achieved strong agreement that remote methods are feasible and can be effectively implemented by healthcare professionals. But there was an agreement that remote methods would be less time consuming for older adults, or that they would be more affordable for older adults, or that they should be offered to all older adults. There was support for implementing reimbursement policies to support the adoption of remote care once proven to be effective and acceptable. But we did continue to see low agreement regarding the reliability of synchronous and asynchronous assessment and management of physical function. There was stronger agreement on the need for further research on the feasibility and effectiveness of different remote methods for assessing and managing physical function, though. So just as for the consumer process, the 19 accepted statements were then reviewed by the working group and were adapted into key messages for experts working with older adults to guide their thinking about physical function and remote care. You can see those 7 key messages on screen here, revolving around recognizing the importance of physical function for older adults, making sure that access to ways to assess and manage physical function is available, acknowledging the feasibility of remote methods for older adults and health professionals, the need also for development of guidelines and policies that recognise physical function and remote care, and obviously, lastly, the need for further research to make sure that what we're doing with remote care of physical function is acceptable, feasible, and effective for both older adults and health professionals. So I'll move on to, I guess, to discuss some of the limitations. I'm sure many of you have already identified a number. Obviously, a key one is that these surveys were only presented in English, and we did have a predominance of people from Australia and the UK in both the consumer and expert processes. There's no doubt, I'm sure, that in other regions of the world, there would be different opinions and preferences around remote care for physical function. We did have fairly strong response rates of more than 80% in the second round of both Delphi processes. But a limitation of Delphi processes that's been acknowledged is that it's pretty likely that the people that you lose in subsequent rounds are probably the ones that feel not represented by the results of the previous round. So it's possible that the people that we lost would have influenced the results somewhat, and that they might have been different. We might have had different outcomes had those people remained a part of the process. Probably most importantly, regarding the consumer process, is that there's likely selection bias. Given this was an online survey, that's more likely to be accessed by older adults who have technology familiarity. And obviously, those with less familiarity with technology are likely to have differing views on the role of remote healthcare. And just to extend on that point, as I mentioned when describing the expert process results, only around 30 to 45% of experts had actual experience of using remote methods to assess or manage physical function. So we maybe didn't have a biased cohort in that respect in terms of favouring remote care. What was interesting was we did some post hoc analyses comparing those with and without experience. And it was noticeable that we had some different perceptions between those with and without experience. So in round one, those with experience of remote care had strong agreement that remote methods were feasible. But the statement overall didn't achieve consensus because of the low agreement, only around 53% from those without experience. And we saw similar differences for perceptions of whether health professionals can implement remote care methods and whether remote care can be similarly effective as in-person methods. So I think we can probably take away from this that, and probably positively, that perhaps the experience of using remote care does result in having more positive views about it, and people recognizing that it does have some advantages. So perhaps over time, as more health professionals are exposed to remote approaches to assessing and managing physical function, we might see increasing acceptance and more readiness to explore developing approaches. So to summarize the findings of these Delphi processes, we achieved a consensus on a number of statements, and these demonstrate that physical function is a health priority. Opportunities to assess and manage it should be made widely available, and that remote care may be a viable option for this where the individuals are capable and the required supports are in place. We're hoping that the recommendations from these processes can inform clinical practice, policy, and future research, as well as the development of new consumer-focused platforms to support remote assessment and management of physical function. And just with that in mind, as I mentioned earlier in the presentation, late last year, we completed some further work, which has been a co-design process to develop a consumer-informed platform on self-management of physical function. And we worked with around 40 of the Australian consumer Delphi participants over several workshops and followed a double diamond co-design framework to initially identify priorities for physical function, determine how those priorities could potentially be addressed with physical function care, with digital health, and finally to develop some prototype digital resources around this. And through this process, we identified 4 key priorities for improving physical function, and these were the need to increase awareness for and promote prevention of poor physical function among those who currently have good physical function, to support older adults themselves to perform self-assessments and monitor their own physical function, and to facilitate access to interventions for managing physical function. And then in developing the resources, these priorities were addressed under the banners of learn, test, and improve. And so this is the prototype website we've developed based on the co-design process. We hope to obtain funding in future that we can develop this further and test it. Much of what is proposed for this website is probably in line with what many of us would think about when thinking about designing a website to support older adults to manage their physical function. But we saw some real benefits of working with the consumers in co-developing this, with some really interesting ideas that arose throughout the discussions. Something that came through very strongly was the need to provide options for both self-management and collaboration with health professionals. So the website tries to support this by allowing people to perform assessments themselves and monitor their changes over time, but also to share their results with health professionals and engage in conversations with health professionals. The improve area also allows people to self-select themselves into different remote digital home-based exercise programs, or alternatively access databases on exercise professionals and facilities in their local areas if they prefer in-person supervised programs. So just wanting to acknowledge, of course, all the collaborators who contributed to the work and the RAMP working group, our consumer and expert participants who gave up a lot of their time to answer a lot of statements, and also thank our funders. As I mentioned, the Consumer Delphi process now available in the journal JMIR Aging, and can be accessed via that QR code. And if you're interested in the expert Delphi manuscript, feel free to reach out to me and I can provide that to you. And I will leave you on screen with those recommendations from the expert process. Thank you, Francis.
Thank you so much, David. There's a lot to unpack there, actually, as I was just thinking through all of the things that you were talking about. And I ask anyone who's interested in asking a question to either raise their hand or post something into the Q&A. And while you're doing that, I had a couple of comments, I guess, and was interested in your response. My mic seemed to, is my mic back on now?
Yeah, it's back on now. Yep, got
okay,
you.
I don't know. It seemed to turn itself off. One thing that struck me is that the older adults seem to be less conservative in a way in their attitudes towards remote, assessment and management than the health professionals. Do you have a comment about that?
Yeah, I think my feeling is that we probably did have a relatively healthy group of older adults. As you saw, about 30% with some physical function limitation. The others seem to be fairly independent and have good physical function. And so I think from their perspective, they obviously feel, yep, I could do an exercise program at home. I don't need to be supervised necessarily. I might like to get some advice on how to get started, and then I would be okay. My perception is that probably a lot of the health professionals, that's not the type of people they see generally. So they're thinking about people who have very obvious functional limitations and that they would be quite concerned about potentially exercising alone, doing things at home. And I think that came through in that kind of asynchronous versus synchronous sort of stuff where the idea seemed pretty concerning to them that there would be no level of supervision compared to a synchronous approach where at least you're observing them and able to see what they're doing. So that's my perception of it, but yeah, not able to say definitively, obviously.
Yeah, interesting. Yep, and yeah, any of our participants, please put a question in the Q&A. I'm also still got a couple of things I'd like to talk about. One thing also struck me was that the older people weren't really that concerned about security, privacy, that kind of thing. And that seems to contrast with some of the literature that we know and some of the work that I've done in which older people are very worried about being scammed and they want to make sure privacy and security is foremost. Do you have a comment about that?
Yeah, I was surprised by that too because I expected that to come through as a stronger concern. And as you say, the literature would suggest that it was. Um, I yeah, I can't really say again whether it was to do with the perhaps tech savviness that they feel relatively confident because it's an online survey. They're people that are on the internet. They might feel more comfortable that they can identify what's safe, what's secure, what's a scam. Some of the conversations we've had has been with those who are a little more tech savvy is that they kind of recognize that all their data is being collected anyway.
Anyway, yeah.
And so they're a little bit more blasé in a sense about that. Whereas I tend to find that in conversations with people who are maybe not so aware of Google's tracking me all the time and things like that, that they are a little bit more suspicious and concerned about, whether they're capable of identifying that. So again, anecdotal, but perhaps, driven a little bit by the fact that they are just a group that are maybe a little bit more confident online.
A more tech savvy group.
Yeah.
And my last comment was really about how we can kind of address the equity piece because, as you mentioned, it's English speaking people, the people who really are having maybe more difficulty with technology accessibility and all of that. having their opinions and how we go about capturing that. Do you have a comment on that?
Yeah, I think it's really challenging. Obviously, it's a fairly low burden way for us to get the survey out there by having it online, but you do likely exclude those people that you're talking about. I think something that we're quite interested in. Obviously, we did this consumer co-design process in Australia only, which was specifically because we think probably on that level where we're starting to develop platforms, it's probably going to be fairly context specific to, the healthcare system that you're working within. And so we didn't think that it would work really to do an international kind of focused one. So something I'm talking about with some of my collaborators, because we do have people in the working group from middle, lower income countries who did their best to recruit for us, but often, as you could see, we weren't able to get big numbers of participants. But having conversations with them around, can we maybe within your country do a little bit more of a focused process with people such as in Brazil, we're talking about, where I think, the access to the technology and the recognition of physical function is perhaps a little lower than you might find in places like Australia and the UK.
Yep. Yeah, I think it's important considerations. We do have a comment and question from Pazit. Thank you, David. Lovely having you presenting here at the seminar. Pazit's interested in what's next. How will this be used in the future and what are the practical implications?
Yeah, hi Pazit, nice to see you. I think one of the goals really now will be to look at developing. We're working with policymakers, potentially industry as well, on the development of resources, but to, I think, really strengthen and develop some guidelines. And again, I think that's going to be maybe country specific. I'm not sure whether we continue with the international process at this point. I think maybe we would target it to Australia a little more, and then, at least for our own purposes, and then maybe work with some of our collaborators to do similar things in other countries. But I think, the things we would like to do are develop, some guidelines. I think with the platform that we're developing, we would like to be able to potentially implement that and make that available, and then have people and obviously trial that and see whether we can actually have benefit out in the community, but potentially influence health outcomes with that. So those are the main focuses for now.
Okay, thank you. And we have another question from G, who has just commenced with NARI as a research fellow. Hi, David. Thanks for taking us through the process very clearly. How would you suggest remote assessment methods to older adults? So should that be through GP if they identify a deficit, or if the older person themselves identifies a deficit? Do you have any thoughts on this?
Hi, G. Yeah, so something that I've focused on quite a bit recently is, and why I guess we're going down the path of this sort of consumer-focused website, is I think we do potentially need our older adults to take a little bit of a leadership role in getting the general practice community aware that this is a priority. And so I think the common thing we hear is that an older person goes to the doctor, they're getting their blood pressure medication checked, they need to get a vaccine update, and the discussion about the fact that they've slowed down quite a bit over the last 2 years just never happens. And so what I think is quite exciting, and it seems to be, again, anecdotal, but I feel that in the last 5 to 10 years, I'm noticing older adults caring a lot more about that and seeing that as something that they want to address than perhaps what I found when I was doing my PhD in the same kind of area. And so part of the idea with this website is a lot about educating and just saying, this is why physical function is important. This is what you can do to obviously maintain and improve it. But this is also how you can have a conversation with your health professional about it and get that discussion started. So I do like the idea of encouraging self-assessment, and then being able to go to the doctor and say, look, here's the results from this website. They say that I've got quite slow physical function. I know a lot of doctors will be tearing their hair out with me saying this. And can we talk about this? Is there something that can be done about it? Because I think unless we have the people themselves going to the general practitioners sort of saying, this is a concern for me, it's probably just going to continue to be a conversation that doesn't really happen. Mm-hmm. And I recognize why that is. The doctors don't have enough time, but we probably need to just raise the level of priority a little bit in their eyes to recognize even, that patient's walking a bit slowly from the waiting room to the chair in my office now. Maybe I should just mention to her that there's this seniors exercise program that might be useful for her. And I think it could make such a difference if we can do that. So that's the approach we're taking. So I mean, ideally we would love to have lots of GPs and practice nurses and other health professionals trained in how to do physical function assessments remotely. And I think that's something we should be looking at. But I'm quite keen on the idea of these simple tests that people can do themselves, just being a nice little screening tool to get the conversation started.
Great, thanks, David. Dave Barry has slipped in a question here, which I guess relates to that umbrella statement, and we may not have time to cover it, so maybe you and Dave can have a chat about that. I guess it's about the adaptation when people do have multimorbidity, cognitive impairment, and low digital confidence, but that probably is a whole, seminar on its own.
Yeah, the reality is, I think, and you often get this with Delphi processes, you do come away feeling there's still a lot of questions unanswered, because really the statement tells us that if you meet these criteria, then remote care is probably feasible, but it doesn't tell us what do we do for those that don't.
You don't,
Yeah. So I think there's a lot further work to be done to kind of go down that path.
And the last comment was, what happened to NARI's How Well Are You Aging questionnaire? It was great to show people how they could improve health. And I can answer that one. Our healthy aging quizzes are freely available on the NARI website. So anyone can have a look at that if you're interested in that, David, as well.
Yeah, I will.
Yeah, check that out, as well as our technology implementation framework. I'm just getting my plug in there. So that's on our website as well.
Yeah,
we've come to the end. What a fabulous presentation. Please join me in thanking David with your clap reactions that you will find under React, I think. And I'd just like to say that next month on the 10th of March, we have Dr. Jackson Fife, and he will be talking on remote physical function testing in older adults, the mixed method study exploring test reliability, feasibility and perceptions of participants and assessor. So it's great to keep this conversation going. Oh, there's someone with a raised hand. Not sure if you can put your question into the chat and we can follow up with David, because we only have a very short amount of time left. Dave Barry, perhaps you can help out on the tech side of things, or perhaps that person can pop their question into the chat or email us afterwards. But it's been great having you all here. Thank you very much again, David, and we look forward to seeing you all at the next NARI seminar. Thanks so much.
Thank you.